Good afternoon. This is Najib Al-Halak. I'm gastroenterologist, oncologist at Karmanos Cancer Institute. I welcome everyone in this Karmanos colon cancer webinar in an honor of the colon cancer month, March. And I'm joined today by two of our experts at Karmanos Cancer Institute, Dr. Steve Kim, surgical oncologist, and Dr. Thomas Kelly, advanced gastroenterologist, who will also be speaking during this webinar. In this webinar, we will learn about colon cancer, and also we will hear from one of our patients, Patrice Calloway, her story about colon cancer. We are really thankful for her to be joining us in this webinar. So overall, the webinar will include a few presentations from us. I will talk about overview of colon cancer, and then Dr. Kelly will educate us about how to prevent colon cancer. Then Dr. Kim will tell us how we do the surgical treatment for colon cancer when it's localized. Then I will actually wrap up the session about what to do after surgery. And then we would like our patient, Patrice Calloway, to tell us about her story of colon cancer. At the end of the webinar, we would open up for questions and answer sessions for all of you. And just a small disclaimer, this webinar will be recorded and will be available for your review on Karmanos website and also social media. In order to respect patients' confidentiality during the Q&A session, we ask you do not share any specific details about any patient. And with that, I will start by introduction first about our gastrointestinal system anatomy. When we eat, the food goes down through the food pipe that we call the esophagus. And then the food will be accumulated in the stomach, which will start the first process of digesting the food. And then the stomach will push the food to the small intestine, which is a very long tube that ends at the here where the colon starts in the right side of our body. The colon starts by going up, what we call that ascending colon, and then goes all the way to the left side that we call transverse colon, and then it goes down all the way to end with this loop that we call the sigmoid colon, and then the rectum, and then that will open up down at the anus. So what is colon cancer? Colon cancer starts inside a colon polyp, as we can see here. We will learn more about colon polyps and how to detect them from Dr. Kelly, but this colon polyps, not all of them, some of them will develop into colon cancer that will grow inside the colon, as we can see here in the right side of the picture. So how does that happen? The cancer developed inside the genome. So what is the genome? The genome is the coding material that is inside in the center of every cell we have in our body. And that has basically the codes for the cell to do the function and to multiply into other cells. Normally, the cells that lining the colon will multiply persistently in every day to be replaced because we eat the food and that will cause the cells to go through the colon also with the food. So we need to replace this lining of the colon. So the cells continuously multiply. And during that multiplication to have daughter cells, mutations, which is an error in that genome that we just saw in the previous slide. And those errors or mutations could accumulate from the first pass to second and third and fourth, and eventually this will develop the cancer inside that polyp, and that will basically multiply in a non-controlled way. Not all of us had the same risk to develop colon cancer, as we can see here in this pyramid here. Some of us will be in the left side, the low risk population, but some of us will be in the high risk population. And then in the middle, we call the average risk patients. Colon cancer is actually now the fourth most common cancer in the United States. It makes about 8.2% actually of all new cancers diagnosed in the United States. That was the statistics from 2020. We see here that there is a peak of the colon cancer incidence, and the median here is 67, but we can see here the age ranges. And we see here that above 50, we see the significant increase, but the real increase started really at age 45. and then significantly more increase at age 50, and then it peaks at age 67. It is well known by statistics that in all different races that male are more commonly to have colon cancer than female. Most of the colon cancer patients, when they present to the doctor, about 70-75% of them will present in a local, or what we call an early stage, as we can see by this pie chart. 35% comes, or 38% comes as localized, not even in lymph nodes, and we'll explain that in a bit. And another third of them will come with what we call a regional, which is basically the colon cancer in the colon spread to the lymph nodes. And then only 22%, about 25% comes with what we call stage 4 colon cancer from the beginning. So we have here, in my opinion, opportunity to improve on this. Why we say that? Because when patients come to us with localized disease, as we can see here, the 5-year relative survival is a 90%. And if they come with a little bit more advanced disease, where we call it regional, where the cancer went to the lymph nodes near the colon, then the chance of surviving 5 years is 70%. But if they come with a stage 4, unfortunately, the survival is slim. So what are the risk factors that lead us to develop colon cancer? Of course, we just talked about the age. We talked about being a male. Obesity is one of the reasons or risks, but of course, none of those by itself will develop colon cancer. Excessive alcohol intake, tobacco, smoking or chewing, low fiber diet. If you have a family history of colon cancer, this will increase your chance, and then you will be pushed, if we remember the pyramid, will be pushed to the right side, to the high risk patients. If you have a personal history of what we call inflammatory intestinal conditions, which is called Crohn's or ulcerative colitis. What are the early signs and symptoms of colon cancer? Rectal bleeding, changing in bowel habits. Sometimes it's constipation, sometimes it's diarrhea. Feeling pressure in the rectal area. Noticing change in the caliber of the stools, becoming more thin. Being anemic is a possibility of colon cancer, especially if it's iron deficiency anemia. Having abdominal cramps, and of course unintentional weight loss, which usually we don't like to have as this is not a beginning sign of a colon cancer, early colon cancer. So how do we make the diagnosis? As we're going to hear extensively from Dr. Kelly today, it's by doing colonoscopy to look inside. What are the stages of colon cancers? We just say colon cancer starts usually inside the polyp, so we call that stage 0. And then it will start making its way through the colon wall. As we can see here, stage 1 goes halfway, almost inside the colon wall. Then stage 2, almost to the end. And then stage 3 goes to the lymph nodes. And we can see the green circles. Those are the lymph nodes. That's stage 3. And then stage 4, unfortunately, when it goes beyond the lymph nodes to a distant organ, as we can see here in the picture, where the colon cancer started in the colon and then sends through the blood, the metastases, we call it, to the liver and lungs and other organs. How do we make the stage of colon cancer when the patient presents? By doing what we call a CAT scan, and sometimes by doing a PET scan. We see here in the black and white, in the center of the image here, this is the CT scan of the abdomen. And in the left and right here, we see different slices of what we call a PET scan. And I usually call it to my patient, I call it the cancer scan, because this helps actually us to see the cancer, as you see here, lighting very bright in the images. Like, for example, the D, you see pointing on that, that's a cancer in the liver. That means the cancer went from the colon to the liver, and we can see that and detect it with a PET scan. So let's learn more about how to prevent colon cancer from Dr. Kelly. Dr. Kelly, please go ahead.
Dr. Kelly, I think you're muted.
Dr. Kelly, you're muted.
Unmute.
Okay, thanks.
Sorry about that. I'm Thomas Kelly. I'm an assistant professor at Wayne State University. I'm sorry about the technical glitch. I also work at Karmanos Cancer Institute. In addition to being a general gastroenterologist, I also do advanced or interventional endoscopy, which is extra training, and I specialize in varied advanced endoscopic procedures that the general community gastroenterologist likely does not do. Today, I'm going to be talking to you about screening and prevention of colon cancer. And let's see if our slideshow works. Can you see my slide? Yes, okay. So this is the United States recommendation on screening for colon cancer. It's actually being updated this year. You can see when you go to the website and look for the recommendations, on the bottom it says in progress. The main page doesn't have the updated version yet, but this is the updated slides that are going to be officially announced very shortly. Previously recommended 50-year-olds and above be screened, but now with this year's recommendation, we are now recommending 45-year-olds and above in all races to be screened for colon cancer. It's not as strong of a recommendation, but it's still recommended, and I would highly recommend it as a gastroenterologist. After about 75, we start individualizing treatment. The goal is to prevent colon cancer death over the next 10 years. So after 75, we start individualizing, you're looking at your other medical conditions. Have you had polyps before, a family history before? It becomes a very individual discussion. But essentially everyone from 45 until 75, almost everyone at least, should be screened for colon cancer. So please talk to your doctor about getting screened if you haven't been screened, and I'm going to tell you more about the process. Colon polyps, most colon polyps can become colon cancer. Not all, there's one type that does not. But the precancerous colon polyps, that's what we're looking for during a colonoscopy, and that's what we're trying to find with early detection by other means as well. These grow, they can be polypoid, or like this one, how do I get a pointer? Pointer options, laser. This one here is more polypoid on a stalk. Others are flat. The flatter ones are harder to see, and you want to have a good gastroenterologist that can see the flatter polyps. It also is really important to have a good clean out, and we'll talk about that a little bit later. There's many different forms of colon cancer screening. One of the older forms is to look for blood in the stool. This is a test that is done every year if it's done appropriately, and it is one form of screening. There's the fecal occult blood test, which is older, or the newer one called the fecal immunochemical test, FIT. If you belong to a healthcare maintenance organization called an AMO, for example, the one that comes to mind is Kaiser in California. They send this to every patient on their insurance because they want to make sure everyone gets some form of screening. And only 50% of people are getting screening right now. We need to improve that. This is one method to improve that. It is not the best method. It often detects cancer instead of polyps, and we want to catch it before it becomes polyps. It can also detect polyps if the polyps induced microscopic bleeding. I often get this question, Doc, I can't see any blood in my stool. What do you mean I'm bleeding? Well, you can bleed such a small amount every day that you won't see it with your eye, but with special tests, we can see microscopic bleeding, or bleeding that would only be seen from a microscope. This is a newer form of stool testing. It is very heavily marketed, and it is called the fecal DNA test. The manufacturer says you can do this every 3 years, but that is not recommended, and it really should be done every year. It is much more sensitive on detecting polyps and cancers than the fecal occult blood test, but it is got some problems as well. It is very expensive. You have to collect the entire stool instead of just a smear of the stool. And if you have a positive, you still have to go to colonoscopy. With the Affordable Care Act, the screening test itself should be free and fully covered by insurance with no copay. But if you have a screening test that's a stool test, then the colonoscopy is no longer the screening test if it's positive. The other problem is that there's a lot of false positives, and we're discovering with this very new test that you'll find a positive. We do a colonoscopy, we don't find a polyp. We then are wondering, did we miss a polyp? I often then immediately repeat the colonoscopy before the patient even wakes up, just to double check that I did not miss a polyp. But we're discovering more and more these false positives, meaning the test was positive, but we can't find a cause for that positivity. And then we have to then individualize, well, what are we going to do next with this? And that's not well studied. The older technique before we had colonoscopy widely available was a flexible sigmoidoscopy. And this dates back to when they thought most of the colon cancers were occurring on the left side, because most of the polyps we can see, especially with very old cameras before we had high definition cameras, were seen on the left side. About 50% of people make polyps, and majority of those polyps are on the left side. And this does prevent colon cancer death over a population. It may not be the best for you though, especially if you are someone that grows a colon cancer or a precancerous polyp on the right side, as this is only investigating this portion here, the left side. Every 5 years is the recommended for this, with some caveats, but most doctors do not do this anymore. If you were in Alaska and you only had a rural healthcare and you were in the office and you had a family practice, they might do this. But in a big city like Detroit, we're going to do a colonoscopy. CT colonography, you might have heard about this. Some people call it a virtual colonoscopy, which I don't like the name virtual colonoscopy. The medical name is CT colonography. It's a CT scan, sometimes called a CAT scan, to look for colon polyps. You still have to take a colon prep. Everybody, is there a test that I don't have to do a colon prep for to clean the stool out? Unfortunately, this is not the one. Again, if this finds a polyp or any abnormality, you still have to get a colonoscopy afterwards. Only about 1% or so of the population gets this. One person that is famous that came to mind that got this while president was President Obama, because he did not want to go to sleep and temporarily hand over the presidency to the vice president at the time. But it is not the recommended way if you come to me for screening for colon cancer. If you do decide to get this, it's better than nothing. It's every 5 years. Not many centers offer it. I would recommend a colonoscopy over this test. And I'd be happy to talk about that later. Barium enema is not used very often at all anymore. It is still in the guidelines for a way of screening for colon cancer, usually in addition to something else. This in 2021 would probably mainly be used in a patient who we cannot complete the colonoscopy due to surgical alterations, severe scarring that's really causing narrowing of the colon. It's rarely used anymore, but it's a way to look at usually the right side of the colon. You can see here's a picture. They insert barium or a contrast into the colon under pressure with a balloon actually inserted in the rectum. It's not as bad as it sounds, but it's not great. I'd rather get a colonoscopy than this if possible, but it's a great way to look if you cannot finish a colonoscopy due to altered anatomy. But even still, a colonoscopy is the best way. A colonoscopy. So a colonoscopy is a scope. You can see the endoscopist here using the scope. It's got a handle and a long insertion tube. The insertion tube is about the width of my finger, my index finger. You have to clean out for it. And in America, I would say 99% of patients choose to get sedated for the procedure. It would be standard of care to get sedation. We provide anesthesia with anesthesia providers to perform that sedation. The colonoscopy, we insert it under sedation all the way up to the top of the colon called the cecum. I usually try to get in the terminal ileum as well. It's not required to go in the terminal ileum, but I like to check in there as well to make sure there's no issues on almost all my patients. It's performed every 10 years. There's many different types of cleanouts. Some are very expensive and new on the market. The older ones are a little bit larger volume, but actually provide the best cleanout. And usually the older ones are usually free. So talk to your doctors, talk to the schedulers about the cleanout of choice. I'm happy to prescribe any of the cleanouts. Some of the cleanouts are even over the counter, and you can mix a very large amount of Miralax with Gatorade and perform a clean out. And we have instructions that we would be mailed to you in addition to telling you on the phone how to do the instructions on the clean out. This is by far the best way to screen for colon cancer, because when we find a polyp, we can take it out right then and there, unless it's very, very large and we want to talk to you about the risks of removing the polyp endoscopically, or if we feel that it would be difficult to get it out in one session. Almost 99% of the time, we would take out that polyp right then and there. There are some caveats if you're on blood thinners and can't stop them, or there are some exceptions, but most of the time, if we find a polyp, we're going to take it out. So let's talk a little bit about colon polyps again. This is the same slide as before, just to remind you what a colon polyp is. Just a brief history of polyps. It started off with before we could do any biopsies, and then we would just be able to find the cancers and just take a little piece of them, a biopsy. We still use biopsies, pinch biopsies at times for extremely small polyps, but we progressed to mainly using snares, which are little metal lassos, to snip out the polyp, and that really helps prevent them to regrow. I'm able to perform a newer form of polypectomy, or removal of precancerous polyps, called endoscopic mucosal resection. And the newest kit on the block, which is only for very, very large polyps, is endoscopic submucosal dissection. We will be offering that soon at Karmanos, but currently I mainly do snares and endoscopic mucosal resections. There's many different shapes of polyps, and this is just a quick table. We're not going to go over it in detail on the different types of polyps. The ones that are ulcers are actually more likely to be cancer, and Dr. Kim will talk about the management of those. Here's a picture of what special blue light that we have. We have white light and blue light to use in the endoscopy. This is a hyperplastic polyp. Here's a different type of polyp, likely an adenoma. This is an adenoma, or possibly a tubular villus adenoma. They're saying this one is a cell-serrated adenoma, and this one is this one here is a carcinoma. You can see that it has an abnormal pattern, irregular. This one needs to go to Dr. Kim or another surgical oncologist. This polyp is large. A community gastroenterologist may not feel comfortable taking this out. If you have an older gastroenterologist who's not aware of newer techniques of removing large polyps, they may not feel comfortable taking this out and may refer you to surgery. I want to educate everyone that I can take out polyps larger than this, and you can avoid surgery. Here's an example of some very large polyps. These are called laterally spreading granular tumors. Theoretically, if these are precancerous, we can take these out endoscopically, and some of these may actually be candidates for the newest form, endoscopic submucosal dissection. We can also take the smaller versions of these out with endoscopic mucosal resection. So questions for your primary doctor, if you need to have a referral to us. Should I have a Karmanos or Wayne State doctor? Or Wayne Health is our newest our group, or a Wayne Health gastroenterologist. If you get a colonoscopy somewhere else, or if you get it here, I want you to ask your gastroenterologist, especially if it's not me, was my clean out good enough? Because really, that's the whole point of doing this. You have to get a good clean out so we can see the polyps and get them out before they become cancer. If the clean out was not good enough, even in one section of the colon, you really should repeat the colonoscopy in 1 year. So it's a really important question to ask. And that dovetails into the next question: when is my next colonoscopy? For quality measures, everyone should be telling their patients when their next colonoscopy is when you have the first colonoscopy. If they don't know until the pathology biopsies come back, then we can give our best guess and give you the final after the biopsies come back. And then if the polyp is not cancer, similar to what I talked about, if it's not cancer yet, and it was not removed or not removed completely, you should ask your general gastroenterologist in the community, should I be referred to an advanced endoscopist or an interventional endoscopist like myself for removal to avoid surgery. Here's my contact information. And I believe Dr. Kim is next. Sorry if I went over.
Thank you, Dr. Kelly. Next will be Dr. Kim to tell us how we treat surgically colon cancer.
Okay, can everyone hear me? All right, well, thank you very much for attending our session. I'm Steve Kim, a surgical oncologist here at Karmanos Cancer Center. Surgical oncologist means a surgeon who specializes in the treatment of cancers. And obviously what we're here to talk about today is colon and rectal cancer. Some of what I'm going to say is somewhat repetitive given the excellent talks that Dr. Al-Halak and Dr. Kelly just gave. You know, some of this may be too simplistic for members in the audience. And if it is, I hope you'll ask me to expound or give more details in the chat at the end of the talk. So what is the role of surgery in the treatment of colon and rectal cancer? So surgery essentially is the only potentially curative therapy. No one can guarantee a cure, but surgical removal is really the only thing that can offer a potential cure. The likelihood of you being potentially cured after surgery is significantly related to what the stage you were at when you were initially diagnosed. So this is something called a survival curve. The vertical axis is your probability of being alive, and the x-axis or the horizontal axis is just time. And what you can see is if you read up from the bottom, the time points, 10 years, 20 years, when you were initially staged at stage 1 or stage 2, you have a much better chance of being alive at these time intervals than if you are staged at stage 3 or stage 4. So being diagnosed at an early stage by getting your colonoscopy and having the diagnosis before the cancer is advanced is your best chance of being cured of this. And remember, Dr. Al-Halak said that the median age of diagnosis in the late 60s. So some of these people who it looks like, well, I only have a 70% chance of being alive at 10 years, even with stage 1 cancer. But remember, most of these people are dying of other things because now these people are in their 70s and 80s. So they're oftentimes not dying of colon cancer. They just have a history of colon cancer that was cured in the past. So we talked about surgery as an option for potentially curative treatment. Surgery can also offer relief of symptoms, and colon and rectal cancers, because of anatomically where they are, can cause some very disturbing symptoms. Dr. Kelly mentioned GI bleeding, which can be very, very upsetting when you see it in your stool. But as Dr. Kelly mentioned, sometimes these cancers bleed a little bit at a time over months and sometimes years, and you never see blood. And the way you find that out is you present to the emergency room feeling completely fatigued, and they find out your blood count is 50% or 30% of what it normally should be because of the chronic blood loss from these cancers. The other more disturbing symptom are symptoms of bowel obstruction. Dr. Al-Halak talked about crampy abdominal pain. Well, crampy abdominal pain is a symptom of possible obstruction that may occur in the future. And then the worst complication, in my mind anyways, if you present very late with a diagnosis of colon or rectal cancer, is intestinal perforation. So I can show you graphically here one of these complications. So this is a CT scan of a patient, and the one on the left is completely normal. And you can see here, these are small intestine, and it's very narrow and thin, as it normally is. This is colon with stool inside of it. This is a patient with an intestinal obstruction, and the cancer is right here at the arrow. And you can see the difference here in the size of the lumen of the intestine above the level of the obstruction and below. And this patient presented with severe abdominal pain, vomiting, and was very, very sick when they eventually had to have surgery. And oftentimes, if you have to have surgery in this kind of emergency condition, you have to have a colostomy. And you can see how dilated these loops of bowel are. And if you kind of ignore this to even later than this, these things can rupture and perforate, which can cause a devastating complication called peritonitis. So let's talk for a minute about the techniques for colon and rectal cancer surgery. This is the how of how we do it. So there's two techniques. There are three techniques. One is the standard open technique, and you can see here what the incision is. It's basically an up and down incision in the middle of your belly. The retractors are placed and the organs are exposed, and then the surgeon basically uses his hands, and vision is by his naked eye to take out the cancer. A newer technique is laparoscopic or robotic. Here the incisions are much smaller, and you can see here this is a typical set of incisions for a laparoscopic right colectomy, and there's a tiny incision here above the belly button, and then even two smaller, tinier incisions in the right upper part of the abdomen. And these are the instruments here that we use. We put them through these tiny instruments. This is a camera that we put through one of these tiny little holes. And we use these instruments to manipulate the bowel and the organs to remove the cancer through these very small incisions. So what is the difference between an open surgery versus either a laparoscopic or robotic surgery? Number one, there is absolutely no difference oncologically. What do I mean by that? What I mean is it does not matter whether you've had the cancer removed in the standard open fashion or whether you've had it removed laparoscopically or robotically in terms of how long you were going to live from that cancer. So the technique of how we do it doesn't change the cancer outcome. What it does change is the size of the scar, which you can see in this patient is a little bit above the size of a quarter. There is therefore less pain associated with the surgery. And there is usually a shorter length of hospital stay if you can do it laparoscopically or robotically. Now let's talk about what are the operations that we do for primary colorectal cancer. And this, again, this is the what part of what surgeons do. So partial colectomy is the operation that's done for colon cancer. A very, very important part of partial colectomy is you not only have to remove the tumor in the colon, obviously, but you also want to retrieve these lymph nodes that are around the tumor. And here in this cartoon, you can see there are these little tiny gland-like structures around various parts of the colon. It's very important that you remove enough lymph nodes with the cancer, because as Dr. Al-Halak mentioned at the beginning of the talk, lymph nodes are how we stage a cancer once it's been removed. So here is, and the number of lymph nodes removed is what we call a quality metric. What that means is that if you have had less than 12 lymph nodes removed for a colon cancer operation, it's felt that that was not a high quality operation. So it's very important that you get enough lymph nodes out to be able to stage the cancer. Here in this set of cartoons here, you can see the example of a couple of operations that we do for partial colectomy. On the upper part, this is a right colectomy, so removal of the right half of the colon and then reconnection of the two ends. On the bottom, it's a left colectomy, so removal of the left part of the colon and then reconnection of the two ends. And essentially what you want is a specimen like this. So here, there's this big, ugly cancer right in the middle of the colon, and then a lot of normal looking colon on either side of that cancer. Those are what's called margins. What that means is you want normal tissue on either side of the cancer just to make sure you've got all of the cancer out, both visually as well as microscopically. That is what the pathologists see under the microscope. Now, what about for rectal cancer? This is a removal of rectal cancer, usually called proctectomy. Operations for rectal cancer tend to be a little bit more complicated and more difficult to do than operations for colon cancer. Now, why is that? What is the difference between colon cancer and rectal cancer? Well, the rectum is, for all intents and purposes, it's just the end of your colon. It is that part of the colon that's about 12 to 15 centimeters above the anal opening, so about 6 inches or so. The problem is the rectum is in the bony pelvis, and if you feel on the side there, you can feel the pelvic bones, and the pelvis is basically a narrow kind of bony tunnel, and it is much more difficult to do a nice wide cancer operation in the pelvis than it is in the abdomen where the colon is, where you can usually get the cancer out with widely negative margins. For this reason, rectal cancer, usually surgical treatment is not enough. Usually for most rectal cancers in the United States, you have to have radiation therapy in addition to surgery in order to more completely treat this cancer. One thing about rectal cancer, and this is what patients always ask about, is if the cancer is very close to the anus, it may be very difficult to avoid doing a permanent colostomy. A colostomy is where the part of the colon above the cancer is brought out to the abdominal wall, and through which stool then is evacuated from the body permanently. So here is an example. This is a view of the rectum, and there's a low part of the rectum close to the anus, a mid part, and a high part. If the cancer is there, you can see you have a lot of working room down here where you can cut it, leaving a good margin of normal tissue below this cancer to reconnect the ends down here. Conversely, if the cancer is here, very close to the anus, it is going to be very, very difficult to get a negative, what's called distal margin or normal tissue downstream from this cancer in order to ensure the cancer has been completely removed. So what that means is then you have to remove the anus as well. And obviously, if you're going to remove the anus, the stool has to be evacuated from the body through a colostomy. Your best chance, if you are diagnosed with rectal cancer, of avoiding a permanent colostomy is to go to a center like Karmanos, where you have expert surgical oncologists, radiation oncologists, and medical oncologists who are experienced at treating this type of cancer and have various new protocols that can be used to try to avoid doing a radical operation that will involve removal of the anus and a permanent colostomy. So the operations for removal of rectal cancer, if the anus is preserved, that is, you're able to reconnect things, that's called a low anterior resection. And if the anus has to be removed, in which case just a scar is left back there in the perineum and a colostomy is formed, that's called abdominal perineal resection. Somewhat rarer operations that are done are something called total colectomy or total proctocolectomy. Total colectomy is where the entire colon in the abdomen is removed, leaving just the rectum. Total proctocolectomy is where the colon and the rectum are removed. These operations are relatively rarely done for cancer. They are done usually in patients with genetic syndromes. So these are patients, Dr. Al-Alaq talked about mutations that cause colon cancer. These are patients who have these mutations in every single cell of their body, including in their germ cells or the cells in either their sperm or their eggs. And hence, these genetic syndromes can be passed on to children. What ends up happening is these people get those polyps that Dr. Kelly showed very nice pictures of, not just in one or two spots in the colon, but throughout the colon because they are at such high risk because of these mutations. And hence, partial colectomy won't do it. Also, in patients who have inflammatory bowel disease, such as ulcerative colitis, which involves the entire colon usually, if you develop a cancer in the setting of this, usually you have to have total proctocolectomy or total colectomy. So I'm just going to show you a very graphic example of someone with a genetic syndrome called familial polyposis. And basically, you can see the specimen here on the right. That is his entire colon. And if you look closely, the entire colon is carpeted with all of these precancerous polyps. And in fact, this one right here actually ended up being an early stage 1 cancer. So the primary role of surgery in the treatment of colon and rectal cancer is removal of the primary colorectal tumor, so the tumor in the bowel itself, and also adequate removal of these lymph nodes around the cancer in order to make sure the cancer is out completely, and much more importantly, in order to make sure we have an accurate stage of what the cancer is, because the stage determines the treatment. And for the most part, if the lymph nodes that I remove contain microscopic spots of cancer in them, then Dr. Al-Halak is going to treat that patient with chemotherapy, whereas if the lymph nodes do not, usually you do not need chemotherapy. Now, what if you have stage 4 disease? Dr. Al-Halak talked about sometimes you can get spread of this cancer beyond the bowel, beyond the lymph nodes, into other organs, like the liver and the lung commonly. Well, you might think, well, once it's spread outside the bowel, you really can't have surgery. Well, that's not always true. It is mostly true, but not always. And patients who have a single site of metastatic disease, for instance, in this cartoon, in the liver, can have actually resection or removal of that site of metastatic disease. And this is a specimen of a patient who had that done. This is that part of the liver in the cartoon that's been removed. And you can see that kind of ugly white cancer there in the middle of the part of the liver that's been taken out. This patient has stage 4 disease because she has metastatic disease to other organs. But if you looked at the original survival curve I showed you, some patients with stage 4 disease still are alive 10 years after diagnosis. And for the most part, it is patients who have metastatic disease that can be removed with an operation. So, all of this here today has been to try to get you to see the guy on the left. If you see the guy on the left, basically, you don't have to see these guys. All right. We're both very nice, but we prefer you don't have to see us, because if Kelly can take it out through a scope and prevent you from getting cancer, obviously that's better for all concerned. If you do have to see me, you want to see me and get it diagnosed at stage 1 or stage 2, so that you have the surgery and then you're done. You don't need to get further treatment with chemotherapy. However, if you have stage 3 or stage 4 disease, we're lucky enough that Karmanos is a comprehensive cancer center where we have medical oncologists like Dr. Al-Halak, who knows all of the newest protocols and the newest data in terms of treatment to give you the best chance of survival, even at stage 3 or stage 4 disease. Thank you very much.
So in respect of time, Dr. Kim, you can go ahead and introduce Ms. Patrice Calloway, your patient.
Okay, I want to just to introduce Ms. Calloway. Ms. Calloway is a former patient of mine who did the very, very smart thing and got her screening colonoscopy. And I'm not going to do much more than introduce her and let this wonderful lady tell her story. I think you're muted, Mrs. Calloway.
Okay, now you can hear me? Hi, my name is Patricia Calloway, and I am a patient of Dr. Kim's and a Karmanos colon cancer survivor. I was first diagnosed in June of 2019, but prior to my diagnosis, I lost a brother to colon cancer. My brother was diagnosed stage 4 in August of 2017. Now, my brother's story is kind of interesting. My brother was diagnosed after he retired from his job. My brother worked 40 years for a medical supplier in California. He retired after 40 years of service to his company in May of 2017. In August of 2017, he was diagnosed, and he was diagnosed with stage 4 colon cancer. His cancer has spread through the lymph nodes to his pancreas. My brother was placed into hospice care in October of 2017, and my brother passed away January 26th of 2018. My brother's birthday is in May. He didn't make it to his next birthday. He did not make it to the first anniversary of his retirement. It was very, it was really sad. It was really devastating to lose my brother like that because he went so fast. A year later, I was diagnosed with it in June of 2019. We have a family history of colon cancer in my family. I lost an aunt, my father's sister, and my father lost his brother to cancer. So it's in the family. I knew that I needed to get diagnosed. I knew I needed to have a colonoscopy because I was in the age group 55. So after I had all of my other things that I have, my mammogram and my lady exams, I scheduled my colonoscopy, and yep, true enough, they found it in June of 2019. I was sent to Dr. Kim for treatment. I saw Dr. Kim in September of 2019. The colonoscopy experience that I had was really very was done very well. I did the clean out the night before with the enema, because I picked up the kit from my pharmacist. I went in the next day. Everyone, from the nurses to the check-in, everything was just so very well done, so very professional. And it was really very important for the intake and the prep prior to the colonoscopy is really important for the patient, because you really, once they tell you, you really do not know what they're going to find. They're looking to see exactly to the extent of what your treatment is going to be. And it's really very important for the steps and for the process to be very well done. I never felt in any step of the process that anyone that I came in contact with did not know what they were doing. Everyone knew what they were doing, from the check-in to the nurse who was prepping me, to the people who gave me my gown. Everybody at the hospital conveyed to me a sense of, we take this very seriously, we take you very seriously, and this is very important to us. The experience was best. It was the best experience I've ever had in a hospital. Now, prior to this, me having my colonoscopy, and prior to me even having surgery, I had only been in the hospital one time, and that was to have a baby. So, you know, I'm not a sickly type person, although I do have this family history of colon cancer. I was asymptomatic, but prior to me having coming to Karmanos for the colonoscopy, I was anemic for a while. And anemia is something else. Iron deficiency anemia is something else that runs in my family. I had the only thing I had was like a change in the texture of my bowel movements, but I had changed my diet prior to that. So I really didn't get, too concerned about that. I did see pink skin, it looked like that. And I realized that finally I realized that those are polyps, but I did see like pink skin, little pieces of pink skin in my, in my stool, and a little bitty spot of blood here and there. But I'm thinking, bowel movement, hemorrhoids. I did have thin stools. But like I said, I had changed my diet, and that was the only thing that I thought of. The day of my surgery, I went through intake, and like I said, everyone was so, it was very reassuring to me. Even if I did have like a diagnosis that maybe I wasn't sure of having, just my peace of mind, I felt that I was in very, very good hands because like I said, everybody at the hospital never conveyed to me at all at any time that they did not know what they were doing. I had my surgery a week after Dr. Kim diagnosed me because I asked him, you know, when should I have this surgery? How soon should I have it? And he said, well, you know, next Wednesday I'm available. So I was like, let's do it. So next Wednesday, I had my surgery. The recovery was pretty quick. I wasn't as sore or as upset or, you know, physically ill as I would assume that I would be to have that type of surgery. And this past September, I had my follow-up and I was clear. So I'm very grateful to Dr. Kim, and I'm very, very grateful to Karmanos for, number one, for treating me so well and for making me feel as if, you know, they took it very seriously. And just that reassurance of knowing that I was going to get the best treatment and that I was going to be treated well was very, very instrumental in me mentally and emotionally. Because when somebody tells you you have cancer, oh my God. And I had just lost my brother, I lost an aunt, and I lost an uncle. So I didn't know how this was going to turn out for myself. And I feel very blessed that it turned out very well for me. It doesn't turn out well for other people, but you need to understand that at Karmanos, they're going to treat you well. So whatever happens, it's gonna be all right. And I'm very honored to be asked to be on this panel because, you know, people get worried. People are just, oh my God, what's going to happen to me? Karmanos is going to treat you right. So don't worry about it. Just have faith and just understand that it's going to be okay. You have the best doctors. You're going to get the best treatment. And even if it doesn't turn out, you're still going to get the best. So I'm very, I feel very, very blessed to have been able to come to Karmanos. Mine was stage 1, they called it. It was creeping around. It was getting ready to start and trying to, you know, establish itself. But Dr. Kim caught it, and I'm very, very, very grateful to Dr. Kim and to Karmanos for the treatment that I received. And that's my story.
I appreciate you really. I mean, we're really honored to have you here on the panel.
Oh, thank you so much. I'm honored to be here.
So we have 5 minutes here that I'd like to actually open for questions from the audience. And I will direct the question to the person best to answer that.
Well, I'm just going to make a comment here. I mean, Ms. Calloway said that she thought we all took things very seriously, and she's absolutely right, we do. But the most important person that took things seriously was Ms. Calloway. She took things seriously in terms of her own health. And, you know, no one's going to tell her she's lucky she had cancer, obviously, but she was rewarded with the fact that she had a stage 1 cancer, which is ultimately highly curable, and she did not need any further treatment beyond the surgery. So I would say Miss Calloway is the one that took things in her own hands and did the right thing.
Yeah, you have to take it very seriously. And I was talking the other day to the panel about a Facebook debate that I had with one of my friends who was asking the question that if you knew that you had cancer, or if you knew that you would get that diagnosis, what would you do? And would you really want to know? And I want everybody who is watching this to understand, yeah, you do want to know. You want to know because you want to get on it as fast as you can. You want to get a treatment option. You want to get a game plan, and you want to make it happen, because the fastest you get in there, the better your prognosis is going to be. You're going to come out better the faster you get in there. So yes, you do want to know. And even if it's bad news, like I said, if it's bad, you still want to know. You want to be able to know how you're going to fight for yourself. And
I have
that's
a
what.
question here in the chat box. Does obesity contribute to colon cancer? It is actually, I'll answer this question quickly here. Yes, actually it does lead to colon cancer. But again, as I said in the beginning, it's not by itself. By itself is not the cause of colon cancer. It has to be with something else. But it is one of the things that can push you, if we remember the slide with the triangle, it can push you to more than the average risk patient if you have obesity. It's not going to, of course, put you as a high risk patient unless you have multiple reasons, like, you know, a male, obese, lack of exercise, low fiber diet, or a family history. So that all will push you to the right side of the triangle where it is the high risk population for colon cancer.
Mine was a family history.
You were a
Yeah.
family history, yes.
Yeah, I had family history.
And
So
that actually gives me the
overweight, and I wasn't
opportunity to
either.
talk about that, you know, after we do the surgery, if patients, you know, do have significant family history, we refer them to our genetic counselor to have a sit down with them and maybe even do a blood test for them, or a test from the inside the mouth. We're taking a sample from buccal mucosa, we call it, to test for genetic mutations that could be running in a family. So it informs the patient and his or her family of their risk of colon cancer or other cancers, of course.
Yeah.
And I'll take a chance here before I get more questions. Please feel free to write your question in the chat box. I just want to make a comment here about after surgery. I didn't have a chance to talk about it. As Dr. Kim and Ms. Calloway say that she was lucky she had a stage 1 colon cancer. Stage 1 colon cancer, almost 100% of them don't get chemo after surgery unless there is a perforation, which is very rare to happen. Stage 3 colon cancer, where it went to the lymph nodes, most of those patients would require chemotherapy after the surgery to reduce the risk of recurrence. The surgery cures, as we say, majority of the patients with the localized colon cancer, but chemotherapy could add 15 to 20% actually of a cure if appropriately done. Stage 2 colon cancer, majority of them don't get chemotherapy after the surgery. There is a small portion of them that requires to have chemo after. There should be a discussion between you and your oncologist about the chemotherapy. What chemotherapy you would choose for me, and for how long. For how long is very important to discuss about how long, 3 months or 6 months. So we have here a question: what is the chance of getting colon cancer in testing if testing positive for Lynch syndrome? Lynch syndrome is actually one of the genetic predisposition for colon cancer and other cancers, like a stomach cancer or endometrial cancer, prostate cancer. So the chance is high, but it goes up with the age. So if you are, for example, a 20-year-old person with a Lynch syndrome, the chance is low. Not low, very low. We're talking about 30% chance. But again, it's with time. It's what's the next 10 years chance at age 40, at age 50, at age 70. At age 70, it's about 70% you're going to have it. 80% you're going to have it, colon cancer. So we do recommend the Lynch syndrome patients to have a conversation with us and with colorectal surgeon as well, like Dr. Steve Kim, because for some of them actually, we do recommend them to have a prophylactic surgery where they remove the whole colon and also removing the uterus and the female organs because of the high risk to develop those cancers with time. So it is not a straightforward answer right away. If you choose not to do a colon resection, then we recommend very strong screening. Maybe Dr. Kelly can say how would he recommend screening then if the patient has Lynch syndrome?
So we do yearly colonoscopies for Lynch syndrome patients, starting at a very young age. Often in the 20s, it may depend on when their first degree relative, meaning like brother, sister, mother, father were diagnosed. But if you have Lynch syndrome and come to me, you know, if you're younger than 20, we'll have a discussion, but at 20, we start doing colonoscopies for sure. Every 3 years, we actually look at the stomach as well. And there's many other organs that need to be screened and they check. You know, it's important to discuss with your geneticist if you have Lynch syndrome on what screenings should you be doing, how often, and Karmanos has an excellent geneticist or team of geneticists for that question. The next question I can answer as well, what's a good prep for a colonoscopy? All preps, if taken as instructed, it can be good preps. Now, some people are on the constipated side, and that's actually one of the questions that I would always ask the screeners to be asking the patients. If you're coming to the office, we'll talk about it. If we're trying to arrange a direct colonoscopy, which we're still working through the process on getting direct colonoscopies, we want to know if you're constipated at baseline, because those patients don't clean out as well. We often will give a laxative like Miralax 2 scoops twice a day for the 5 days leading up to it. Sometimes we'll do an extra amount of prep. If you're doing the older Go Lightly prep, instead of the 4-liter container, some people do 6 liters. So everyone usually does fine with the generic amount, but if you're constipated, let us know and we will give you a little extra, make sure you have a good clean out.
One thing to add about the Lynch syndrome is one of the ways you can kind of recognize whether you potentially may have it is if you yourself was diagnosed with colon cancer and the cancer happens to be on the right side of your colon and your age of diagnosis is in your 40s, and you have a first-degree relative who also had colon cancer, that is a classic patient who possibly has Lynch syndrome. So that's a way you can kind of recognize that you may have this familial type of colon cancer.
Or if you hear actually a family member with stomach cancer or
endometrial cancer
with the uterus cancer, actually that right away will click, to us to that you have a high chance of having Lynch syndrome. We do have a lot, several Lynch syndrome patients in our clinic, some of them with diagnosed cancer that was removed. They are now some of them getting some chemotherapy after, and they chose actually to just have an annual screening with the colonoscopy instead of actually doing a total colectomy. We had this conversation, me and Dr. Kim, about one of those patients. And his recommendations is that the patient could choose actually to do yearly colonoscopy, and I don't have to remove the whole colon if she chooses to. So I think it's an important dialogue that needs to happen in a multidisciplinary team. Means like not just only the medical oncologist really speak of that. Several people, including the medical oncologist, surgical oncologist, and the genetic actually counselor of your choice. We have a question here about how often colonoscopy for multiple myeloma patients. It's a very interesting question, actually. We do see colon cancer in multiple myeloma patients, probably a little bit more often so it's not, I would not call it that average patient or more than average patients, but there is really no formal guidelines for those patients. You probably should be, in my opinion, screened every 5 years if you have a multiple myeloma, 3 to 5 years, but that's just based on my experience with those patients. Dr. Kelly, you wanna add something?
So I agree, there's no formal recommendation to my knowledge. I have not specifically looked up a multiple myeloma society, but in the general gastroenterology society recommendations, I'm not aware of a specific multiple myeloma recommendation. I think it's important to have a discussion. Depends how you're doing with multiple myeloma. The goal is to prevent death from colon cancer over the next 10 years. So if you plan on living longer than 10 years with your disease, then yes, I would definitely get screened for colon cancer. And then how often we get screened can be individualized.
I think that one thing is that, you have to expand this question for patients with other cancers who are already being treated for other cancers, whether they should be screened for colon cancer. I would echo exactly what these two said. There is no definite protocol, but it's something that you should discuss with your oncologist. If you have a stage 4 breast cancer, for instance, it is likely that a screening colonoscopy is not going to add years to your life. If you have a stage 1 breast cancer and you're 5 years out from treatment and are free of disease, then definitely a stage 1 a patient with a stage 1 breast cancer should have screening colonoscopy. So it is a discussion you have to have with your oncologist and also your primary care physician.
don't see another question coming, so I think we're 8 minutes beyond the time. So with that, then we'll conclude and thank everyone from the panelists who actually joined me today in this interesting educational webinar. We would like to do that more often, actually. And appreciate Ms. Calloway, honestly, really huge thank you to you for joining us in this. And thanks everyone who attended this and asked any question. Appreciate you. Thank you so much.
Thank you so much for
Bye-bye.
having me.
Bye-bye.
Get
Bye-bye,
screened, folks.
everybody.
Thank you.